You can start, sir.
See, good evening, everyone. Today I am going to teach something about the EEG. I don't know it is a teaching or it is a learning for all of us. And see, like when we talk about the EEG, most of the time, like when we think about the basics, I always has a wonder what is basics. Like the lecture today is a EEG basics. Basic is the one thing where only the person who teaches knows and other people don't know. That is a basic. Like a examiner always asks, you don't know this basic question also. No, basics are most difficult because the person who asks only knows about the basics. And when we start the EEG from the very like whatever the first 1 or 2 chapters of the EEG, like a basics, they always talk about the physics, they talk about the electrodes. So by the time we will reach at the end of the second chapter, we lose our interest on EEG. So that's why I thought we will go from the what we know, what we practice every day, to the rather than going from the bottom to the top, you come from the top to bottom. I thought that might give you the better understanding of the EEG. All of us know like a brain is electrically active structure. So basically what you are recording the electrical activity of the brain. So when you are recording the electrical activity, you remember that you are recording the alternate current. Whenever you keep a alternate current in mind, alternate means it is like a sine waves. They might come up and down. They are like a ripples. The sine, so you are recording the current from the brain. What kind of current you are recording? You are recording the alternate current. When you are recording the alternate current, like that is like a sine wave kind of thing. First, I will show some basic waveforms, and from there we can move forward. Like a see in this slide, you are seeing there are a random waves. Don't think about the like a channels or the montages and those things. First, try to identify the waves. So in this one, randomly.
The slide is not okay. Alpha activity. Okay.
Okay. So when you are seeing this slide, don't think about what is the voltage, what is the montage, what is the channel and those things. First, be familiar with what you are seeing on this one. You are seeing some waves, and they like the waves which are like a sine waves. So what you are going to record from the brain is the sine waves. They are like a AC current. All of us know AC current is like a sine wave like current. So in this slide, like as I know all of us was in a final year exam going, at least we know that odd numbers represents the left side, even numbers represents the right side. So in this one, if you see, like there are waves which looks almost like a monomorphic. They are there in every second of the like in this page. So whenever we are seeing the EEG, you have two things in mind. Is it a normal or abnormal? And what we are recording the electrical activity of the brain. So is the electrical activity coming from the brain is normal or abnormal? That is the question we have to answer at the end of our EEG reading. So for that EEG to be we have to label it as a normal or abnormal. We should have a familiarity with what are the normal activity in the brain, what are the normal waveforms we will see in the brain. And at the same time, you should have a familiarity with the abnormal waveforms. How many abnormal waveforms we have? Only two. One is a spike and other one is a sharp. How many normal waveforms you have? You have either alpha or the sleep structures. And whatever the high fancy things of the benign sharp waves, those either you identify or don't identify, that doesn't matter. So you have two things in mind. One is you want to identify the normal waveforms, and we wanted to identify the spike and sharp. So in this one, at least everything looks monomorphic, and as the like you are seeing the some waveforms which are looking like both, they are present both on the right side and the left side, and they are the they have a field. Yeah. And you can see this one also. So this also shows the similar one. So this I am showing only to make you familiar about the what we are going to talk about next. Okay, in this page you can see two things. One, once you close here already has written, yeah, already here written like a first half and the second half if you compare, and there is a difference between the first half of the page and the second half of the page. And the first half of the page, you are not seeing the first half of the page, you are not seeing any activity, whereas in the second half, you are seeing the waveforms. So when we are reading the EEG, what we have to see is you are recording the electrical activity from the brain, and you have to see the reactivity of that electrical activity. Then only it is a meaningful. So for that, we see a eyes closed and eyes open. So if there are a waveforms which was there when you are eyes closed, and if they are disappeared when you are opened the eyes, means your brain is reactive. If you are seeing the not a reactive waveforms, means the either you can say patient is in a drowsy state or sleep state or coma state or whatever, the reactivity indicates that brain is not active at that moment. So now you saw that there are a waveforms which are coming, and here also you can see with eyes open and eyes closed, there is a difference. So it is a reactive waveforms. Whenever we see a waveforms, first thing is identify the waveforms. So anything which is like a sine wave like thing is a waveform. If number of waveforms are more than 9 to 11, you will call it as a alpha. If they are between 4 to 8, 4 to 9, you will call it as a theta. If they are less than 3, 4, you will call it as a delta. So in the slides, whatever I showed, if you go back and see, now count the number of waves in the here in the first wave. If I take a 1 second, maybe first, second, third, fourth, fifth second, and number of waves are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So if you have a 9 to 11 waves per second, you will call this as a alpha activity. Alpha is predominantly you will record from the occipital region. If it shows the reactivity, means it is a reactivity means alertness of the brain. Something which is reactive is a alert. So what we learned from till now, we learned that EEG is to record the electrical activity from the brain. Our electrical activity resembles the AC current. AC current is like a sine wave forms. And after knowing this one, we know what we record is in the EEG is a normal and the abnormal activity. Any electrical activity, how do we know it is a normal or abnormal? So we need to have a mental picture of what is the normal activity. Normal activity is divided into alpha, theta, and delta activity. Alpha activity is 9 to 11. Theta activity is up to 8. Less than 3, 4 is the delta activity. And other thing what we noticed in these slides in the first half of the slide and second is first half you have a alpha. The once you open the eyes, there is a disappearance of the alpha. This shows that there is a reactivity. The second thing, once the patient goes into the sleep, you can see the alpha is disappearing, and then you start seeing some waveforms which are like a broad and sharp. If the broad and sharp waves, we will define what is spike and what is sharp later. Like anything which is a pointed wave which stands against the background is a spike or sharp. So it has to be it has to stand against the background with a pointed edge. If the duration is less than 200 milliseconds or more than 200 milliseconds, but there is no difference between the either spike or sharp, they denote the same. So vertex sharp, the why we will call sharp waves, even this sharp wave is not an epileptic one. These are the like a normal appearing which comes at the vertex. You can see like if they look like a sharps, but they are not epileptic. Once the patient goes into the drowsy, you will get the sharp waves in the vertex region. They are normal. Then you can see K complex. You are seeing here there is some like a sharp like thing followed by the spindle like activity. They are called the K complexes, the similar one. So once you go to the sleep, you can see the number of waves you are seeing become less. Here in a per second, you are seeing maximum 2 to 3 waves. So what it indicates, once you go to the sleep, number of waves decreases. So it is as good as a coma. So till now you have seen what you see in a normal EEG. So once you connect any person to the EEG, you are expected to see the alpha waves first predominantly in the occipital region. How do you know what is alpha? It is based on the counting the number of waves and the area where it is coming the maximum. If it comes in the posterior region of the head with the 9 to 11 Hz, they are called the alpha waves, and they should. And then what we did next time, reactivity with eyes closure and opening we saw, and then we realized that that is a reactive if they are disappearing with eyes open. Then once you become little sleepy, you will see there are waveforms. They are called the vertex waves. Then we saw the K complexes. Then we saw the very slow waves of the 2 to 3 Hz in a deep sleep. So from the awake to sleep, if you see the number of waves, what you saw 9 to 11 in the initially, when you go to the sleep, it is a 3 to 4. So then like a number of waves are decreasing. And hey, Prabhu. How to? And next we are going to see some focal abnormalities. So till now you saw the normal waves, alpha waves, delta waves, vertex waves, and the sleep spindles. And abnormal ones are spikes and the sharp waves. Or spike and wave things, polyspike and wave things are the like a intermittent rhythmic delta activity. Spike is they are transient and they are clearly distinguished from the background activity with a pointed peak, and the duration should be 20 to 70 milliseconds. The main, like we'll talk about the main component, what is negative and positive. So what is spike? It has to be a transient. It has to be a clearly distinguished from the background activity with a pointed peak. The duration doesn't matter, like a 20 to 70 milliseconds. Amplitude can be variable. Whereas a sharp, it is also same. It is a transient, clearly distinguished from the background activity. This is the most important thing. It has to be clearly distinguished from the background activity, and with a pointed peak, the duration is 70 to 200 milliseconds. The main component here is also negative. So you have a two abnormal things. One is a spike and the other one is a sharp. Both are has to be a transient and the clearly distinguished from the background activity. And you can see here, and here you can see the in this page you have only one area which is a clearly distinguished from the background and which looks the pointed and it has a field. So these are the spikes. And here also you can see in this whole page, whichever looks little like they are transient, you can see they are not there everywhere in the page. They are transient, clearly distinguished from the background. They have a pointed head tip. And the similar thing you can see here. This is like in the whole page, you can see one area where the number of waves are less. You can see somewhere in the left side, frontotemporal region, you can see the number of waves coming are only 2 or 3. So if you see the rhythmic delta activity, delta means less number of waves in one region rhythmically, that is also epileptogenic, that is also a abnormal. So here you can see again the which are distinguished from the background in a third second spikes. Similar thing, similar. So what is the learning point from all these slides? It has to be transient. It has to be a distinguished from the background activity and should have a spike, the pointed edge. This sharp or spike can followed by a slow wave, spike and slow wave. Here we are seeing the spike and slow wave. Next. So till now, I showed you the yeah. Just ask. Hello. Yeah, I am audible.
Yes.
Hello.
Yes, sir, you are audible. You can continue.
Screen is visible, na? Hello.
Yes, sir. Yes, sir. Yes.
Yeah. So even though I thought of starting from the technical aspects of the basics, but I started with the showing the normal waves. The reason is once we start with the like a very basic, like because what we are going to see is the finally the output. So I thought they understand better by starting like this. So like what we are going to see
one student is requesting whenever you want to show anything, you can use the pointer. Any particular finding.
Yeah. Okay.
Yeah. Thank you. Dr. Ramkrishna, can you mute this other person? Abhishek, can you mute yourself? Continue.
Yeah. So in this technical aspects, I thought I will cover the history, little bit, what generates the EEG, what are the methods of recording, and something about the electrodes, machine, and the montages. So like Richard Catton is discovered the EEG in animals in 1895, and Hans Berger is the first to record the human EEG and named it as a electroencephalogram. And you can see this is what we are from the now, like in the first few minutes, we saw, okay, there are waves coming from the brain and we name them based on the number of waves per second. If either alpha, theta, delta, that is the number of waves coming for the second. Who generates these waves? At the same time, those are the normal. And we saw the spike and sharp waves, which are transient and clearly distinguished from the background. So now we have a mental picture of the what actually the output coming from the EEG. Output coming from the EEG is only two varieties. One is the like a normal waves and abnormal waves. Normal waves based on their number we designated, and the other one is a spikes and sharp. But who generates it and how to record these waveforms? So who generates it? This is the, like we know that all the basic things starts at the synapse. You have a soma, you have an axon. Soma contain a multiple dendrites and like a multiple synapses between the either junction where axon or the some other portion of the one cell terminates on dendrites, axon or soma. So it is a junction. At this junction, actually, either excitatory postsynaptic potentials or the inhibitory postsynaptic potentials will develop. So you can see here the soma and the axon. The axon terminates on a dendrite. So when axon terminates on the dendrites, that forms a synapse, and we are recording the activity from these synapses. Can we record from the one synapse? It is not possible. So it is a collective activity from the multiple synapses. So what you are recording is the postsynaptic potentials, which are summated from the multiple synapses. So you can see here, but you are not recording directly putting the electrode from the synapse. You are recording from the scalp. So there are a lot of barriers between your where actual generation and where actually you are recording. And all of us know when you want to record something, always it is the difference between the 2 points. Means it is the, when we talk about the current, what is the first word I used? I used the, we are trying to record the electrical activity from the brain. Electrical activity comes with the potential difference between the 2 points. So what you are going to record is the potential difference between the 2 points. And here, like why I went to that one is you are trying to record the electrical activity from the synapses, especially postsynaptic potentials. These postsynaptic potentials are the summated ones. For example, if you have a multiple inhibitory postsynaptic potentials, you record something. If you have a multiple excitatory postsynaptic potential, you record something. So something means one kind of waveforms comes from the excitatory and one kind of waveforms comes from the inhibitory potentials. But say because of the lot of barriers between the actual generation and the recording, it may not reflect the accuracy as it is at the basic level. So here, you can see, there is a, in the middle, you are seeing a one neuron with intracellular potential of the minus 70 millivolts. Whereas you can see here, inhibitory postsynaptic potential, it becomes minus 80 millivolts. It is a difference between the extras, like a potential difference between the how the resting cell with the minus 70 went to the minus 80 in, it is a inhibitory. If you see, if it is a excitatory, you can see it is a minus 60. And whereas full-blown action potential, you can see up to plus 15. So the sources of EEG are synaptic and non-synaptic, but it is predominantly from the synaptic. So where we record actually this one, our EEG is predominantly recorded from the pyramidal neurons. So our cortex, it is the synaptic potential of the pyramidal neurons are the major source of the EEG. And currents are relatively slow and the summate to produce the visible waveforms. Each synapse acts like a battery. I will explain how it is. And the driving current is like a small loop. Both excitatory postsynaptic potentials and the inhibitory postsynaptic potentials contribute to the synaptic activity recorded on the EEG. ఇది రావట్లేదంటే each synapse acts like a battery and the driving current forms a small loop. And yeah, you can see here, I wanted to show one diagram. Yeah, you can understand better here. If you see like here you are seeing the two diagrams. One is a and other one is a B. If you see A, in the layers of the 2, 3, you are seeing whenever there is a excitatory potential, you can see a lot of positives will go inside the cell. So what is there in the extracellular surface? It is the negativity. But if you see at the soma, you can see the positive. So this negative at the dendrite, positive at the soma, it is like you can see there is a dipole now. You have a negativity at the dendrite, positivity at the soma. Actually, this forms the mini loop. And so when you have a negativity at the top and a positivity here, and you see the diagram B, it is also excitatory potential, but this excitation is not at the surface level. It is at the below level. Here, when you have a excitatory here, and you see a lot of positives will go inside. Here you have a negative charges. Here you are seeing the positive charges which are normal. So it forms a loop. So for the electrical activity to be recorded, you need the two things. One is a positive and other one is a negative. It is like a dipole. You need the two different charges, positive and the negative charges. So it depends upon the where is the excitation. Like if the excitation is near to the surface, you see the negativity there. If the excitation is near to the base, means in the layer 4 and layer 3, you see the positivity on the top. Here, like if you see, both are excitatory, but the kind of waveform what you are going to record from the surface is different, because near to the surface in the diagram A, you have a negativity. Near to the surface in a B, you have a positivity. So it depends upon the excitation is at the top level or the deep level will determine the what kind of waveforms you are going to record on the surface. So yeah.
Dr. Ramakrishna, somebody has written something with bluish ink. Can we delete that?
No, sir, it's not from our Zoom.
Okay.
Hello. Yeah. So now you can go from here. The synaptic potentials of the pyramidal neurons are believed to be the major source of the EEG. So we are not going to record anything from the deeper activity. We are recording only from the surface. So when you are recording from the surface, there are obviously blind spots. You can't record from the base of the brain. You like a orbitofrontal or the basal temporal, you cannot record it. We don't have a electrodes to record the interhemispheric space also. So, and the deep structures obviously it will not represent. So what EEG represents, it represents the only synaptic potentials of the pyramidal neurons, and it is the summated either excitatory or the inhibitory potentials. And like I showed you the diagram earlier, when you are viewing from the extracellular space, current flowing, inside is sink, outside is a source. Like a, because it was, if you see this diagram, inside is a sink. Like I told you, this is an excitatory potential here. All positivities will go inside. So this is called the sink. This is called the source. Extracellular one is called the source. Inside is called the sink. Okay. So a model is compared with the neuron where dendrite is positively charged and the soma is relatively negatively charged, causing the potential difference. Normally results in the generation of the current in a extracellular membrane. That's what you saw. Many dipoles in the different phases unite to form a normal EEG pattern. Whatever I showed you, like there are a different synapses. Each synapse forms a one excitatory potential. It is a summation of the excitatory and the inhibitory potentials which gives the like a final waveform. Excitatory currents are mainly because of the sodium and potassium ions, and the outward current is predominantly passive one. Inhibitory currents are due to the chloride and the potassium. So non-synaptic currents are because of the fast action potentials, because of the short duration, high amplitude sodium channels, and calcium channels also contribute in a action potential. Okay. So what is the major origin of the discharges? Major location of the sinks and sources are in the cortex. I told you sink means like a neuron, it is predominantly represents the neurons, like where the current flows in. Sources are the extracellular spaces. So what we record is the difference between the for example, if the dendrite develops the excitatory postsynaptic potential, then when you compare the dendrite with soma is in a negative and the dendrite is in a positive because of the excitatory. So that creates a dipole, and these kind of dipoles unite to form a waveform. So by summarizing it, you are recording the waveforms. What is the source of waveforms? Source of waveforms is the pyramidal neurons. Where you are recording, it is the dendrites. So postsynaptic potentials at the dendritic level is what you are recording. Are these waveforms representing any deep structures? No. Are these waveforms representing the basal and the medial structures? No. So you are recording only from the surface and it represents the pyramidal neurons, and you are recording from the postsynaptic potentials at the dendrites level. So, and I think this much is enough. If somebody asks you what you are recording, we are recording the electrical activity from the pyramidal neurons. And like when we are thinking about the how the EEG will be recorded, imagine you have a patient and you paste the electrodes and then you will connect it to the amplifier. When you connect it to the preamplifier, and the Montages is the way of collection, then you have a low frequency, high frequency filter, and then you amplify it, then it will come. So when you go to the EEG lab, observe like you have a patient, electrodes, and electrodes will go and connect to the amplifier, and remaining everything you see on the screen, like a low frequency, high frequency filter, amplifiers, what is the sampling rate, and those things. Same thing. So previously we used to have a paper, or like I don't think any of us has seen a paper recordings. Now it is all the digital one, and it is more advantageous. All of us know, and the number of channels available and the specificity, and you can change and see. And what kind of electrodes we will use? Electrodes transmit the electrical potential from the brain to the EEG machine. Electrodes made of a metals like a silver, copper, gold, platinum, or stainless steel. Silver electrodes most useful in recording the potentials of the very low frequency, and they are the most frequently used ones. So we use the two types of electrodes. One is a scalp electrodes, needle, clip, nasopharyngeal we will not use. Very rarely, in a few centers, sphenoidal electrodes they will use, because to record from the mesial temporal lobes. These are the upper one is the sphenoid electrode. So skin when to minimize the resistance, the skin preparation is important. Remove the surface oil and the surface layers of the epidermis, either with the acetone, alcohol, or soapy water, and attach the electrodes to the skin with colloid, and the thick paste normally we will avoid. It is a similar one showing the preparation and the electrode placement. And so heads do not come the heads do not come in a standard shape, and some people can have a microcephaly, macrocephaly, skull abnormalities in neonates, etc. Need for the standardization of the placements. So we use the 10-20 system. I will tell you what's 10-20 system. So uniformity between the technologies, uniformity between the examinations is in the same patient will help if we have a standardization. So here you can see measure the distance between. So what is the concept of the 10-20 system? Inter-electrode distance is constant. Like in this system, you measure the distance between the inion to ocean, and the first electrode is like, for example, you have 100 centimeters. So first electrode placement is 10% of the total distance. From that point onwards, 20, 20, 20, 20, and again like from ocean you take a 10%. So first electrode placement from the inion is 10%, from there 20%, from ocean also 10%. If you see the distance between the electrodes, any electrodes, like when you place it is constant. So in 10-20 system, first from the landmark, first electrode is placed 10% of the 10% means 10% of the total distance. From the 10 remaining everything from that point 20%, 20, 20, 20, and 10. And the same in the coronal plane also. From the some preauricular point, like you will measure the distance and take the first 10%, 20, 20, 20, 20, and 10. So in 10-20 system, the distance between any two electrodes is constant. From the landmark, first electrode is placed at the 10% of the total distance, and remaining ones are at the 20%. And you can see like even numbers are on the right side, odd numbers are on the left side. So how many electrodes you have in the frontal side? If you see, FP1 is called the frontal, FP1, FP2 will be the frontal pole, and midline you have a 3 electrodes like a FZ, CZ, and the PZ. And the front on the, if just concentrate on the left side. So frontal pole you have a FP1, and the frontal you have a F3, and the central you have a C3. Almost C3 comes around the central sulcus, and then P3, and the temporal you have a F7 anterior temporal, and the T3 mid temporal, and the T5 posterior temporal. And the occipital you have a O1, and the parietal you have a P3. So here, if you see, like you take the distance between the inion and ocean, and you take the 2 auricular points, and you take a like a 10% in first for the first electrodes, and from that 20%, 20. So if you see the distance between the electrodes are the constant. For example, you see the distance between the FP2 and FP1, it is a 20%. From the FP1, if you see F7, it is a 20%. So the distance between the electrode is a constant. So in a even numbers are on the right side, odd numbers are on the left side, and you have a frontopolar electrodes, frontal F3 or F4, and you have a central, parietal, and the temporal. Temporal you have a 3 electrodes. Occipital you have a 1, and you have a midline electrodes, frontal, central, and the parietal. The same thing you can see from the Nacian, like you take a 20% will be the FZ. From the FZ to CZ, 20%. CZ to PZ, 20%. From the PZ to inion, it will be the 20%. And wherever you see the, like it is a distance between the electrodes, it is a constant. So you have a right and left, and the frontal you have the frontopolar you have a 1 electrode, frontal 1, temporal 3. So maximum represented one is the temporal one. It is the same thing. 10-10 system means electrodes become more overcrowded, and so the artifacts become more, and but your preciseness will be much more. The distance decreases in a 10-10 system. So here the inter-electrode distance, instead of 20%, it become like a 10%. And the lead location you can see, FP1 represents the frontopolar, whereas F3 represents the proper frontal lobe, F7 predominantly anterior temporal lobe, T3 mid-temporal, T5 you have a posterior temporal, O1 occipital, P3 parietal, and C3 comes almost near to the central sulcus. So ability to pick up the difference of the electrode potential between the 2 electrodes, while there is a something called the CMR, common mode rejection. So we don't want the common between the 2 points. What we want is we want the difference between the 2 points. So this is what the ability to pick up the difference of the electrical potential between 2 electrodes while rejecting the common potential. So our amplifiers have a common mode rejection, where they reject the common potential between the 2. So amplifiers obviously increases the size of the potential difference to a level at which they can be recorded easily. And the discrimination, that you can the other one what we have is a sensitivity. It is defined as the ratio of the input voltage to the output pen deflection in a EEG channel. It is normally described as a millivolts per millimeter. and it is a 7 microvolts per millimeter. So like don't look into all these. Like what you see on the paper is the wave. If you want to change the sensitivity, and I will show you how to change the sensitivity, and like normally we will record at the 7 microvolts per mm. So we use the two kinds of filters. One is a low high frequency filters and the low frequency filters. What these filters are: high frequency filter, other name is a low pass filter, and high frequency filter number is specified. They will say it is a 70 or 35, whatever. The number indicates which particular frequency has been reduced or attenuated in an amplitude by the maximum attenuation allowed. For example, if I put the high frequency filter at the 70, anything above the 70 will get the attenuated and they lose their quality, but not that anything above the 70 will not visible. They are visible, but they visible at the drop in the amplitude. I will show you the example. See the effect. Yeah, 1 second. For example, if we keep the high frequency filter at the 70, anything about the 70, they lose the quality of the waveforms. Whereas the low frequency filter, if you keep at the, for example, 1, anything less than 1 will lose, anything above that 1 will come as it is. For example, if I keep the low frequency filter at the 1, means anything above 1 frequency waveforms comes unaltered. Whereas in a high frequency filter, if you keep at the 70, anything above 70 will get attenuated. Is the same concept. So notch filter. So you have a 3 kinds of filter. One is a low frequency, other one is a high frequency filter. So you normally we keep the low frequency filters at the 0.5 or 1, so that waves above 1 will come as it is. We keep the high frequency filter at the 70. It allows the waveforms up to the 70 to come as it is. Anything above 70 can get the attenuated, or they lose the quality of the waveform. And whenever I say, like, don't be in a concept that if I keep at the 70 high frequency filter at the 70, anything above the 70 will get completely attenuated. All the waveforms, they lose the 30% gradually. And whereas in a notch filter, if I keep the, like for example, notch filter at particular frequency, that frequency will not appear on the screen. So it can block one particular frequency. For example, if I keep the notch filter at the 60 Hz, anything which comes as a 60 will be blocked. So that is the difference between the low frequency, high frequency and notch filter. Low frequency filter will allow the frequencies above them and attenuate the below frequencies below it. High frequency filter will allow up to the number whatever you set. Above that, they drop the 50%, like a 30%. Whereas notch filter will block the one particular frequency. I think it's the same to show the filter settings. So you have a what are the we commonly use the term montages. What is the montage? It refers to the particular combination of the electrodes examined at the particular point in time. So like the way you connect the electrodes are that is called the montages. There are a different, we use the commonly two montages. One is a bipolar and other one is either reference or the monopolar. In a bipolar montage, you measure the potential difference between the adjacent electrodes. Whereas in a monopolar or the reference montages, you compare the individual electrode with the average of everything. Okay, so that is the difference between the bipolar and the unipolar or the reference electrodes. So these are the two common things we use, bipolar electrodes and the referential. So bipolar connect the pair of electrodes, pair of different electrodes to each amplifier. It localizes sharply the peaks of the potentials. Can distort the shape of the widely distributed potentials, like when we are discussing. So you can see here bipolar so you connect the adjacent electrodes FP1, F3, F3, C3, C3, P3, like that. So in a bipolar montage, you connect the FP1, F8, F8, T4, T4, T6, T6, O2. Again, you can see FP2, F4, F4, C4, C4, P4, P4, O2, FZ, CZ, C. So you are connecting the adjacent electrodes in a bipolar montage. So same transverse montage is also a bipolar montage, but you connect transversely. So this is a reference I told you, like it is each electrode will be compared with the overall potential of all the electrodes. Okay. So like by summarizing the things, what we learned in the last 30-40 minutes was, we know that we are going to record the alternate current from the brain. Alternate current comes as a sine waves. It is like a AC current. And based on the number of waves, we designate them as a alpha, theta, delta, number of waves per second. And there are a normal waves and abnormal waves. Normal waves comes in every individual, and we see the reactivity of those with eye opening and closing. Abnormal waves are two types. They are spike and sharp, either spike and wave, sharp and wave. And these spikes and sharps they are transient. They are clearly distinguished from the background activity. And if they are less than 70 milliseconds, you will call it as a spike. If it is between 70 to 200, we will call it as a sharp wave. And while recording, what you are recording is the electrical activity from the post synapses. They are predominantly from the pyramidal cells, and the outer layer of the cortex is of the pyramidal cells. So you are recording from the dendrites, and you have the dipole is formed between the dendrite and soma because of the excitatory or the inhibitory potentials. And if you have a multiple what you record the wave is the summation of these postsynaptic potentials. The summation, if it is excitatory, it comes in one way. If it is inhibitory, it comes in a one way. And while recording, like we keep the 2-3 things in mind. One is what kind of sensitivity, filters, notch filter is on or off, and the montages. We have two montages commonly we will use. One is a bipolar montage or the referential montage. Bipolar is a potential difference between the adjacent electrodes, whereas a referential montage is we will take the average of all the electrical activity recorded and compare each electrode from that.
Okay, thank you, Dr. Suresh, for presenting this basics in EEG. If anybody have any question, they can ask. They can unmute themselves and then they can ask, or they can put in chat box. Then Dr. Ramkrishna, can you coordinate? Sir, remaining two classes will be case-based,
Yeah.
exam-oriented.
Yeah. One we will take for the only just to show the each and every syndrome and the representative EEG. I thought we will divide into the two. One is a generalized epilepsy and other one is a focal epilepsy. And we will show all the EEGs of generalized in one class and one class focal epilepsy.
Okay, one question is there, sir. Importance of sensitivity.
See, like if you want to make the one wave visible, it is if you are seeing, for example, 200 millivolts wave, you don't know that is an artifact or that is a wave. So reduce the, if it is a 200, you make the sensitivity bigger. Normally we see at the 7 microvolts per mm. So that one you increase a little bit to the 10, 15, 20. So you play with it and so that you know that that is a, what kind of wave that is, it an artifact or is it a real wave? See, and one more thing I forgot to emphasize is how to know something is wave coming from the brain or outside the brain. All of us know that electrical activity has a field. So any electrical activity coming from the brain has a field. So it has to be represented in the adjacent electrodes. If the activity comes from the single electrode, it is likely to be an artifact. So always look for the field if before you are saying that that is a spike or sharp, because at the end of all the easy reading, what you have to identify either spike or sharp. So for that, any spike and sharp before calling, see does it have a field or not. If it has a field, then fine. If it doesn't have a field, it is likely to be an artifact. So sensitivity is only for us to know what is the amplitude of the waves coming, and by changing the sensitivity, you can be little more confident that it is a normal or abnormal, like a artifact or the genuine wave.
Sir, you have any presentation for artifact also for 5-10 minutes?
Okay. So next class I will show in the beginning artifacts then.
Okay. One question is there, sir. When do we use notch filter?
See, normally in India, our electrical activity is 60, I think. 60. We will keep the, because all the other, whatever the electrical interferences, now our light, fans, ACs, all works at the 60 Hz. Okay, each country has some different fixed number. So the notch filter is to the external electrical activity elimination, one particular frequency. Ours is a 50 Hz. So we will keep the notch filter at the 50 so that it nullifies all the electrical activity around us.
Okay, 50 or 60, sir?
50. 60 is Europe, 50 is India.
Okay. Then next question is how to select a notch filter exact value frequency to block particular frequency?
No, it like our settings, it will be given, like if you can choose that one. In a say, like when we see the screen, There, when the notch filter is like normally we have a one option, notch filter is on or off. Okay, like in a, you go to the instrument settings and like a settings, there you can change the frequency.
Sir, sometimes it is very difficult whether the particular thing is sharp wave or
Yeah.
whether it is a spike wave or whether it is just a artifact or whether it is a normal wave. So how these three things can
Like
you show us like?
no, like one thing what I thought was if we are in a doubtful to identify the spike or sharp, don't call it as a epileptogenic. If that is a doubt for you, it will be a doubt for everybody. So look for the better wave. Second one, I told you, na, if it has an electrical field, then it is coming from the brain. If it is not having the electrical field, then it is an artifact. And the doubtful waves, always look for the more record to clarify yourself rather than committing yourself in the beginning.
Anybody have any other questions?
Sir, in pediatric EEGs, we will see all high amplitude things reported as abnormal. Please comment on that.
See, like what is spike, what is sharp, what is normal wave? See, we need to be very clear in our mind. Something which comes, it has to be a transient. It has to be a come against the background activity. It should have a pointed spike. Even though there are 1,000 waves in front of you, your eyes should hunt for only transient, sharp or spike with pointed edge. You should not be confused because there are 1,000 waves in front of you with the different morphologies. What you are going to look at is a very simple. You are looking at the sharp pointed transient ones. And the only one thing is, if you need to be clear that is coming from the, there is an artifact or that is coming from the brain. So look for the electrical field. If it has a field, if it is a transient, standing against the background with pointed spike, then it is abnormal. Most of the time when we see the bunch of waves, we lost this concept and we will be confusing.
Sir, what is electric field? Can you explain in detail?
Electrical field means, for example, you have a spike coming from the F3. Okay, so for example, if you have a spike coming from the F3, I shared on the screen. What are the adjacent electrodes? F7, FZ, FP1, and the C3. At least these electrodes should have that field. Okay, if you are seeing the activity only at the F3, not in the surrounding ones, means it is likely to be an artifact. Okay.
Yes, sir. Thank you. Anybody have any other question? If nobody have any other question, we can close the session. Thank you, Dr. Suresh, for nicely presenting these basics. Though it was very sometimes very difficult to understand, but the basic things are basic. In next two classes, sir will give us some lights on the case-based EEG. So next two classes are very important for exam. Thank you, Dr. Suresh sir, and thank you, Dr. Ramakrishna and other students for participating in this session. We can close this session. Thank you, everyone. Ramakrishna, you want to comment anything?
No, sir. Next two classes will be interesting.
Yeah, Suresh sir, you can give closing remark and then we can stop.
No, I think I feel basics are, this one is a little difficult, basic class. I also don't know how to start it because whenever we start with the physics, all of us will lose the interest. That's why
Yeah.
like we
Though
start.
it was not interesting, but the basics are basics. Once we will understand, then we can analyze the other abnormal EEG and artifacts. Okay. Thank
Yeah.
you, everyone.
Yeah.
We will close the session.
Yeah.
Thank you.
Sir, thank